Welcome back. We are diving into a detailed clinical review session today, and we're focusing on, well, one of the most high-stakes areas in head and neck radiation oncology.
Oh, absolutely, the oral cavity.
Specifically, when the mandible gets involved. And this isn't just about, memorizing facts.
No, not at all. It's about taking this huge stack of sources imaging, path reports, surgical notes, and building a single, reliable framework you can actually use in the clinic.
That's it.
Because for any tumor that's touching the floor of mouth, the alveolar ridge, the retromolar trigone, the mandible is sort of the elephant in the room.
It dictates everything.
It dictates everything. Marginal versus segmental resection, how you stage it, and of course the big one, long-term morbidity, osteoradionecrosis or ORN. So our mission today is really to give you that practical, structured approach to handle these cases flawlessly, from invasion patterns all the way to the pitfalls of planning around titanium hardware.
Okay, so by the end of this, you should feel confident answering three, I think, really critical clinical questions.
Let's hear them.
First, when does the mandible absolutely have to get full dose coverage? And when can we maybe try to spare it?
The big trade-off.
Second, what are the key dosimetric and, maybe even more importantly, the non-dosimetric drivers of a patient's ORN risk?
Yeah, what can you actually control?
And third, how do we navigate the technical, nightmares of planning when you've got titanium plates and free flaps right in the middle of your field?
It's a huge challenge.
Let's unpack all of this using a classic case.
Perfect.
So our anchor patient is a 63-year-old woman. She has a pretty significant 40-pack-year smoking history.
Right. High-risk profile from the start.
She comes into the clinic complaining of pain, and she's having a lot of trouble with her lower denture. And this has been getting worse for about 4 months.
Okay.
Clinically, this all tracks back to a 3-centimeter squamous cell carcinoma in the right anterior floor of mouth.
And on exam, you can see this ulcerated mass. It's fixed to the lingual gingiva. And what's really worrying is it feels firm, almost stuck to the mandible underneath.
Ah, that's the red flag right there.
Big red flag.
Yeah.
And when you palpate the neck, you feel a 2-centimeter firm node in the right level IB region.
So that fixation plus the nodal disease,
Yeah.
You're already thinking potential T4 disease, right? And maybe needing chemo.
Immediately. Yeah, your alarm bells are ringing.
So the workup is where the complexity really starts. And this is where you need to interpret that whole stack of sources like a pro. First up, the CT neck scheme. It shows the tumor is right up against the lingual cortex. And crucially, there's focal cortical irregularity.
Okay, so right away, irregularity is code for suspicious for erosion. The CT also confirms the nodes, a 2.2-centimeter one in IB and a 1.5 in level 2.
But we can't stop there.
No, you can't. CT shows you the cortex, but you have to assess the marrow, and that means MRI.
And the MRI shows the most concerning finding, abnormal T1 hypointensity in the mandibular marrow, right next to the tumor.
And that tells you everything. The normal bright T1 signal, which is just fat in the healthy marrow, it's gone. It's been replaced by something dark.
Tumor.
Most likely, yeah.
We get a PET CT to check for distant disease, nothing, just the FDG avid primary and the nodes.
Right.
Biopsy comes back, moderately differentiated SCC. So the case goes to tumor board.
And the consensus is pretty clear, right? Strong concern for cortical breakthrough and marrow invasion.
So that's clinical T4A, and with the nodes, clinical N2B.
And the surgical decision just flows directly from that imaging. If you suspect marrow invasion, you have to act like it's there.
Which means?
It means a composite resection with a segmental mandibulectomy. You're taking out a full-thickness piece of the jaw. You're disrupting the continuity.
And that's followed by a right modified radical neck dissection, and then a fibular free flap to rebuild the jaw.
Exactly. So the patient gets booked for this huge surgery, and then the chart lands on your desk for post-op radiation planning.
This is that moment. The oral boards moment.
Yeah.
Where you have to show you've connected all those dots, imaging, path, surgery, and now planning risk.
You have to have that framework ready to go.
You really do.
Okay, so this is the synthesis. This is how a resident should deliver it, exactly like this. This is a 63-year-old woman with floor of mouth squamous cell carcinoma. CT suggests cortical disruption, and MRI shows T1 marrow replacement concerning for marrow invasion. We're staging this as clinical T4A, N2B, M0 preoperatively, with final pathologic confirmation after mandibulectomy. Surgical management requires segmental mandibulectomy because suspected marrow invasion precludes marginal resection. Fibular-free flap reconstruction will restore mandibular continuity. Postoperative radiation is indicated based on pathologic rift T for a bone invasion and nodal disease, with chemotherapy added only if ENE or positive margin is present on final pathology. I would aim to start PORT within 6 weeks of surgery. Planning considerations include the native mandibular stumps remain at risk for osteoradionecrosis. The fibular bone flap is vascularized tissue with different complication patterns. Titanium hardware causes CT artifact requiring MRI fusion for target delineation, and preoperative imaging is essential to define original tumor extent. When tumor involves the mandible, I treat to full dose and do not underdose to spare bone.
That summary really hits all the core principles. But let's rewind just a bit, because the absolute pivot point here is the T-staging.
It is.
Examiners aren't just testing if you remember the categories. They're testing if you can spot the nuances that determine if a patient, keeps their jaw or not.
It's so critical because oral cavity staging is unique, especially around how we define T4A. You have to be methodical.
So step 1 is always the T4B check. This is your quick screen for locally unresectable disease.
Right. Invasion of the masticator space, pterygoid plates, skull base, or if it's encasing the internal carotid artery.
If you see any of those, you just stop. It's T4B. You're not thinking about curative surgery and PORT anymore.
No, that's a whole different ballgame palliative intent, maybe some intense neoadjuvant therapy.
Okay, so assuming it's resectable, we move to T4A, and I like to call this the 2 doors of T4A.
Right, they're 2 totally separate paths to get to the same stage.
So door number 1 is adjacent structure invasion. This is the one that's relevant to our case. It's invasion through the cortical bone of the mandible or maxilla into the maxillary sinus or involving the facial skin. The key word is through.
Right. If that tumor gets through the cortex and into the spongy, cancellous bone or the marrow, boom, it's T4A.
Doesn't matter how big it is.
Doesn't matter how big it is, doesn't matter the depth of invasion. The anatomical invasion itself drives the stage.
Okay, so that's door 1. What's door number 2?
Door number 2 is the size plus DOI rule. This is for tumors that haven't broken through bone or other structures yet.
So the cortex is still intact.
Intact. A tumor becomes T4A this way. If it's greater than 4 centimeters in size, and its depth of invasion, or DOI, is greater than 10 millimeters.
And both have to be true.
Both have to be true. It's an AD rule. This makes sure that a really big, deeply infiltrating tumor gets upstaged, even if it hasn't quite hit the bone yet.
Let's clarify DOI, because we use that acronym a lot. What exactly is it?
So DOI is a pathological measurement. The pathologist measures from the deepest point of tumor invasion up to the surface epithelium, or, if it's ulcerated, up to the basement membrane.
And it's a huge prognostic factor.
Massive. It's a key driver for deciding on elective neck treatment, too. A small tumor that goes really deep. That DOI, greater than 10 millimeters, if the tumor is also over 4 centimeters, that pushes you right into T4A.
So our case, with the MRI suggesting marrow invasion, that puts us squarely in door 1.
Exactly. But here's the trap. This is the nuance examiners love.
The alveolar ridge tumors.
Yes, alveolar ridge and gingival tumors. If a tumor just causes some superficial socket erosion or maybe a little surface irregularity right where the teeth are, AJCC says that is not automatically T4A.
Right, you need true cortical breakthrough.
You need true verified penetration into the deeper cancellous bone or marrow.
Yeah.
If it's just on the surface, you have to go back to door 2, the size and DOI rule to stage it.
And that's a huge distinction because a superficial T3 lesion might still be treatable with a less morbid marginal resection.
That's the whole point. Okay, so from staging, let's talk anatomy. Because understanding how the tumor moves through the bone informs everything we do next.
Yeah.
You have to visualize the mandible not as a solid block, but more like a protective shell. You've got the dense outer and inner cortical plates.
The buccal and lingual sides.
Right. And inside that is the cancellous or spongy bone and the fatty marrow.
And the second the tumor gets through that dense cortex, it's like a submarine breaching the hull.
That's a great analogy.
Yeah.
Yeah, the soft cancellous bone and marrow, they offer much less resistance. The tumor can spread rapidly.
And what else is in there?
The blood supply. And crucially, the inferior alveolar nerve. This is a branch of V3, the trigeminal nerve. It runs right through the mandibular canal and comes out at the mental foramen.
Which is a highway for perineural invasion, PNI.
A superhighway. If the tumor gets in there, we have to chase it with our high-dose PTV, sometimes all the way back up to the skull base at foramen oval.
Okay, so that anatomy gives us the 3 patterns of invasion that guide the surgeon's hand.
Exactly. Number 1 is the erosive or pressure pattern. The tumor just sits against the periosteum, causing some surface erosion from pressure, but it doesn't actually get inside.
And the implication there?
Potentially, a marginal mandibulectomy is on the table. It's not T4A.
Okay, pattern 2.
Infiltrative invasion. This is where the tumor breaches the cortex and gets into the canthellous bone or marrow.
And that is?
That's definitive T4A disease. And that requires a segmental mandibulectomy to get clear margins. This is what we suspect in our case.
And the third one?
Alveolar ridge or socket erosion, just superficial involvement at the tooth socket. The implication here is that staging depends on size and DOI, and you need careful pathology to distinguish it from true infiltration.
So the staging and the surgical plan are just completely intertwined with these 3 patterns.
Absolutely.
And the moment of truth for differentiating those patterns comes down to imaging. We use the mnemonic, CT shows cortex, MRI shows marrow. Let's dig into why that's true.
Okay, so CT is all about density. Bone is super dense, and that high contrast between the cortical plate and the soft tissue next to it makes CT amazing for seeing structural integrity.
Is the cortex intact? Is it eroded? Is it destroyed?
Exactly. But CT is not great at seeing what's inside the bone. It struggles to tell the difference between a soft tissue tumor that has replaced the marrow and just normal fatty marrow. They look too similar.
And that's where MRI comes in.
It flips the script. MRI uses T1 signal to look at the fat content of the marrow. Healthy fatty marrow is bright on T1.
Right.
Any replacement of that fat by tumor, infection, edema, causes a T1 hypointensity. It goes dark.
Okay, but what's the clinical challenge? The gray area?
The gray area is that MRI is really sensitive, but it's not very specific. A dental infection or just inflammation after a biopsy can also look dark on a T1 image.
So it could give you a false positive for T4A disease.
It could. And on the flip side, CT might not show cortical destruction until you've lost like 30 to 50% of the bone mineral, so it can give you a false negative.
So if the MRI shows T1 hypointensity, but the CT cortex looks pretty solid, how do you handle that uncertainty?
You know, in high-risk SCC, if that MRI shows definitive T1 hypointensity, most surgeons are going to proceed with a segmental resection.
You err on the side of caution.
You have to.
Oh, yeah.
You stage clinically based on the worst finding. Our #1 job is to avoid a local recurrence in the bone, because that's often impossible to salvage. We accept the higher morbidity to maximize the chance of a cure.
And that decision leads us straight to the 2 main surgical pathways, marginal versus segmental.
Marginal or rim resection is what you hope for. It preserves the jaw's continuity, much better function, simpler reconstruction.
But it's only an option if.
Only if there is absolutely zero evidence of marrow invasion, and you can leave at least 1 centimeter of jaw height for stability.
And if you do a marginal, what's the radiation planning implication?
The entire residual native mandible is now your classic OR in risk. Your high-risk CTV has to cover that whole surface where the tumor was, and you have to work really hard with your IMRT plan to spare the inferior border of that bone.
But in our case, it had to be a segmental mandibulectomy, full thickness removal, which means reconstruction with a fibular-free flap.
And now we're in the technical rabbit hole.
Yeah, the hardware artifact.
This is where planning can just go off the rails. The fibula gets secured with these massive titanium plates and screws, and that creates 2 different clinical risks and 1 huge planning problem.
Let's start with the clinical risks.
Okay, 2 different tissues, 2 different risks. First, you have the native mandibular stumps, the cut ends of the original jaw. They are irradiated native bone, hypovascular, hypocellular. They're the highest risk site for classic ORN.
And the second tissue?
The vascularized fibula flap itself. It's generally much more resilient because it brings its own blood supply. It's less prone to ORN, but you can still get things like plate exposure or flat failure.
Okay, now, the planning nightmare, the titanium hardware artifact. Why is it such a disaster?
Titanium is incredibly dense. So on your CT planning scan, you get this huge beam hardening effect, which causes these bright and dark streaks all over the image.
Which hides the anatomy.
It totally obscures the surrounding soft tissue.
Yeah.
But even worse, it completely messes up the density calculation that the treatment planning system uses to calculate dose. The CT numbers around the metal are just garbage.
So you can't reliably contour or calculate the dose.
Exactly.
So how do you solve this?
It's a multi-layered solution. First, for imaging, you have to request metal artifact reduction, or MAR, protocols on your CT scanner.
Okay.
Second, for contouring, you cannot rely on the post-op CT alone. It's mandatory to fuse a post-operative MRI. MRI sees metal as a signal void, a black hole, but there's much less distortion in the soft tissues around it.
So that lets you see what you're contouring.
Yes. But then, third, you have to define where the tumor was. So you must fuse the preoperative CT and MRI to reestablish the original extent of the disease. This is often the only way to accurately place your high-dose PTV66 Jajai volume.
And what about the dose calculation itself?
You have to verify it. You can't just blindly trust what the computer tells you next to the titanium. You have to check that the dose isn't being artificially jacked up or lowered. Some physicists will even override the density of the metal to water just to get a more stable calculation.
Wow, that is a lot of work. So once you've done all that fusion, what exactly makes up the high-risk CTV?
We follow the GORTEX and HNCIG guidelines. The high-risk CTV has to include three things: the native mandibular cut ends, the entire adjacent soft tissue bed, and critically the flap interface.
That seam where the new bone meets the old tissue?
Yes. The surgeon's clips are your roadmap. That interface is a huge risk area for microscopic disease, and it has to get the full prescription dose.
Okay, so since we've decided to treat that whole area to full dose, we are accepting a higher risk of ORN. We have to manage that risk.
Aggressively.
Let's start with the definition. What is ORN?
Classically, it's exposed, non-healing bone in an irradiated field that's been there for 3 to 6 months. It shows up as pain, infection, exposed bone, sometimes even a pathologic fracture.
And it can happen years later, right?
Years, even decades. The median time is often cited as around 17 to 27 months, but the risk is lifelong.
The classic understanding was the 3 H's: hypoxia, hypovascularity, hypercellularity. Is that still how we think about it?
It describes the result, but the modern thinking is that it's really driven by radiation-induced fibrosis and chronic inflammation. Radiation damages the small blood vessels and the bone-building cells, the osteoblasts, leading to this chronic, non-healing state that just can't handle any kind of trauma.
Okay, so given that chronic fragile state, what is the single biggest trigger that pushes a stable, irradiated jaw into acute ORN?
It is overwhelmingly trauma. And in the mouth, that almost always means dental extractions after radiation. The compromised bone just can't heal the socket. It breaks down, gets infected, and you get exposed bone.
So let's talk about the dosimetric side first. If the bone is not involved by tumor, how do we use IMRT to lower that risk?
If the tumor isn't touching the bone, we have to be super aggressive with our plan optimization. The risk of ORN tracks with the volume of the mandible getting a high dose.
So we look at metrics like V60 and V65.
Exactly. The volume of mandible getting 60 gray or 65 gray. The goal, depending on your institution, might be to keep the V60 below 5 or 10% of the total mandibular volume. You use IMRT to create these really steep dose gradients that just fall off right at the edge of the bone.
But the most important prevention strategy isn't dosimetric at all.
No. The crucial board pearl is pre-radiation dental extraction. You must screen the patient's teeth before you start. Any teeth that are non-restorable, have bad periodontal disease, they have to come out.
Before radiation starts.
Before. With at least 2 to 4 weeks for the sockets to heal. You're getting them out while the bone still has a full tank of gas. It's full vascular supply. This eliminates the #1 future trigger. It's non-negotiable.
And what about lifelong care?
It's mandatory. Dental surveillance every 6 months, meticulous oral hygiene, and daily fluoride trays to keep the remaining teeth healthy. The patient has to understand this is a lifelong commitment.
So let's say the inevitable happens. A patient develops a painful abscessed tooth 2 years after full dose radiation to that spot. It has to come out. What's the protocol?
The normal rules go out the window. This is a high-risk procedure. It requires a full multidisciplinary approach.
Okay.
You coordinate with dental oncology or oral surgery. They have to use an atraumatic technique, minimal force, minimal bone manipulation.
And antibiotics.
Prophylactic antibiotics are mandatory.
Yeah.
And then you need strict follow-up to make sure that little wound actually heals.
What about hyperbaric oxygen, HBO? Does it have a role in preventing this?
For prophylaxis, the HOPON trial gave us a clear no. Giving prophylactic HBO before a dental procedure in an irradiated field did not reduce the rate of ORN. It was about 6% in both arms.
Okay, so its role is really in treating established ORN, not preventing it.
Exactly. And for treatment, the main medical option people talk about is the Delanian protocol.
Which is?
A combination of pentoxifylline and high-dose vitamin E. Pentoxifylline is supposed to improve blood flow and reduce fibrosis, and vitamin E is an antioxidant. The evidence is a bit variable, but it's an option for early-stage cases.
Okay, let's come back to the core clinical trade-off.
Yeah.
T4A tumor invading the mandible. What is the absolute unbreakable rule that has to guide your plan?
The rule is absolute. When tumor invades or abuts the mandible, we do not underdose known disease to spare bone.
Period.
Period. Local control trumps everything else. A recurrence in the bone is way more devastating and life-threatening than a managed case of ORN. You accept the risk, and you manage it with prevention.
Give me the bird-safe statement.
When tumor involves the mandible, I treat to full dose. I don't sacrifice local control to spare bone. I accept the ORN risk and counsel the patient about lifelong dental precautions.
Perfect. So let's synthesize this into a decision-making algorithm, an if-then ladder.
Let's do it.
Okay, so if the tumor is just abutting the periosteum with no cortical penetration,
Then a marginal mandibulectomy might be feasible, and your radiation plan focuses on minimizing V60 to the bone that's left.
if imaging suggests invasion through the cortex into the marrow, clinical T4A.
Then segmental mandibulectomy is required, and your plan's focus shifts to the cut ends and the flap interface.
If a fibular-free flap is performed.
Then you have to remember that the high ORN risk is in the native stumps, not so much the flap itself.
If you've got titanium hardware artifact.
Then fusing the pre-op and post-op MRI is mandatory for contouring, and you have to verify your dose calculation near the metal.
And finally, if the tumor was invading or abutting the mandible.
Then the entire high-risk area, the cut ends, the flap interface, gets treated to full dose. No compromises.
That covers the primary site perfectly. But our patient also had nodal disease. And the nodal status is what determines if we add concurrent cisplatin.
Yeah, it's the single biggest decision for survival in the post-op setting, and it all comes down to one biologic driver: extranodal extension, or ENE.
Right. It's not just size or number anymore.
Not at all. ENE is everything. It's a microscopic tumor that is broken out of the lymph node capsule and is now in the surrounding soft tissue. That finding dramatically increases the risk of recurrence and distant mets.
So the staging system reflects that. Let's run through the pathologic end decision tree, starting with ENE.
If ENE is present, the staging just jumps.
Okay.
If ENE is in a single ipsilateral node that's 3 centimeters or less, it's pathologic N2A.
And if it's in a bigger node or multiple nodes?
If that ENE node is bigger than 3 centimeters, or there are multiple ENE nodes or any contralateral ENE node, the patient goes straight to PN3B.
Wow. And ENE is what mandates concurrent chemotherapy based on the big trials like EORTC 22931 and RTOG 9501.
That's right. The evidence is rock solid. In patients with ENE, adding cisplatin significantly improves local control and overall survival.
Okay, so what if ENE is absent?
Then you go back to the classic rules: size, number, and laterality.
Using the 3 and 6 centimeter cutoffs?
Correct. Single node 3 centimeters or less is PN1. Single node over 3 up to 6 is PN2A. Multiple ipsilateral nodes, none over 6, PN2B. Bilateral or contralateral nodes, PN2C. And any node over 6 centimeters, even without ENE, is PN3A.
You've got to have that sequence down cold.
You do.
Okay, let's apply all of this back to our case, a floor of mouth cancer. We need to define our nodal target volumes.
Floor of mouth is a near midline structure, so it can drain bilaterally. Your nodal map has to be comprehensive.
So what do you cover?
You have to cover level IA, the submental nodes, because that's a primary drainage basin. You cover the ipsilateral levels IB through IV because she had known disease there.
And the contralateral neck?
Because of the midline location and her N2 disease, you have to seriously consider elective coverage of the contralateral levels I through 3rd. It's standard practice.
And Beddoes levels.
High-risk volumes: the surgical bed, the cut ends, the flap interface. Any nodes with high-risk actors get 60 to 66 gray. Intermediate risk, like the rest of the dissected neck, gets 54 to 60, and elective volumes, like that contralateral neck, get 50 to 54 gray.
So let's run the 2 post-op scenarios. Scenario A, pathology comes back, negative margins, no ENE.
That's post-op radiation alone. High risk gets 60 gray, electives get 50 to 54, no chemo. And you must start within 6 weeks of surgery. That timing is critical.
Scenario B path report shows a positive margin at the bone cut, or ENE is present in the nodes.
That's post-op chemoradiation. You boost the high-risk volume up to 60, 66 gray, and you add concurrent cisplatin, usually 100 milligrams per meter squared every 3 weeks. And again, you start within that 6-week window.
Okay, before we move on, let's circle back to that difficult conversation with the patient about ORN risk.
Yeah, delivering this message clearly but without scaring them half to death is a real skill.
It is.
It has to be done with empathy, making sure they understand the trade-off. I'll just deliver the script exactly as I would.
Okay.
Mrs. Patient, The surgery removed your cancer, along with a portion of your jaw where the tumor had invaded. The surgeon rebuilt your jaw using bone from your leg. This is called a fibular free flap. Now we need radiation to the area to kill any microscopic cancer cells that might remain. Because the tumor was invading your jaw, we need to treat that area to full dose. This increases the risk of a complication called osteoradionecrosis, where the jawbone doesn't heal well after radiation. To minimize this risk, you'll need to see a dentist regularly for the rest of your life, use fluoride trays, and avoid having any teeth pulled from the areas that received high-dose radiation. If a tooth ever needs to come out, we'll coordinate with oral surgery to take special precautions. Do you have any questions?
That communication is just so vital. Okay, let's use this last segment to really hammer home the common pitfalls. The board traps. What's trap number 1?
Sacrificing local control for bone sparing. We've said it, but it's the #1 mistake. Seeing a tumor invading bone and trying to underdose it to, prevent ORN.
It's a recipe for disaster.
It's a guarantee for local failure. And salvage is grim. The right answer is always full dose and manage the ORN risk proactively.
Okay, pitfall number 2.
Ignoring the need for pre-treatment dental clearance. Just forgetting to check or assuming the patient will deal with their bad teeth later. That assumption creates the single biggest ORN risk factor down the line.
You have to get those teeth out before you start.
You have to.
And trap number 3.
Misinterpreting the imaging in post-op planning. Specifically, failing to fuse the preoperative imaging.
Right.
You cannot accurately plan your high-risk CTV around a surgical bed if you don't know where the aggressive disease was to begin with. Just using the post-op CT with all that artifact is a setup for a marginal miss.
Okay, let's distill all of this into our clinical pearls. The high-yield takeaways.
1. T4A has 2 doors. Adjacent structure invasion or size greater than 4 centimeters, anti-DOI greater than 10 millimeters.
2. CT shows cortex, MRI shows marrow. Use both.
3. Marginal mandibulectomy preserves continuity. Segmental requires reconstruction.
4. The fibular free flap is gold standard. The native stumps are the classic ORN risk.
5. Pre-radiation extractions prevent ORN. Post-radiation extractions cause ORN.
6. ORN risk tracks with high-dose mandible volume. V60, V65.
7. Do not underdose tumor to spare bone.
And 8. Start PORT within 6 weeks.
That's the list.
Time for the rapid synthesis drill. 4 key questions. Ready?
Okay, ready.
Question 1. T1 hypointensity in the marrow next to a floor of mouth tumor. Interpretation and surgical approach.
Interpretation is concerning for marrow invasion, clinical T4A. Surgery is segmental mandibulectomy.
Question 2. Segmental resection, fibula flap, but pathology is negative margins, no ENE. How do you delineate your PORT target?
Include cut ends, soft tissue bed, and flap interface in the high-risk CTV fused pre-op imaging. Start PORT to 60 gray alone within 6 weeks.
Question 3. A patient needs a tooth pulled from the irradiated field 4 years post-RT management protocol.
Coordinate with dental oncology, enzymatic technique, mandatory prophylactic antibiotics, close follow-up, no prophylactic HBO.
And question 4. A 2-centimeter lower alveolar ridge tumor with 5 millimeter DOI causes only superficial socket erosion. T classification.
It's T1 or T2, staged by size and DOI. It's not automatically T4A without true cortical breakthrough.
Okay, quick fire round. Modality for cortical bone destruction.
TT.
Nodal factor that dictates chemo.
ENE, extranodal extension.
What causes the worst artifact?
Titanium hardware.
Classic site for ORN risk in a fibula reconstruction.
The native mandibular stump.
The biggest non-dosimetric trigger for ORN.
Post-radiation dental extraction.
And the priority when treating involved bone, local control, or ORN prevention.
Local control. Always. So to wrap this all up, the most crucial principle here really hasn't changed. When tumor is established in the bone, you have to prioritize cure. You treat to full dose.
Right.
But the sophistication of modern IMRT now lets us be incredibly aggressive in minimizing the risk to the uninvolved parts of the mandible. We can use dose constraints like V60 and V65 to protect that inferior border.
And while our case definitely needed a segmental resection, there is emerging data trying to preserve the mandible. Can you briefly touch on the Shawkar trial?
Sure. The Shawkar trial looked at using neoadjuvant TPF chemo in patients who had tumors near the mandible, but without clear radiographic evidence of bone erosion.
So no T4A disease yet.
Exactly. The hope was to shrink the tumor and allow for a less morbid marginal resection instead of the segmental one. And they achieved about a 47% preservation rate in that very select group.
But the limitation is key.
The limitation is huge. If you have the strong imaging evidence of marrow invasion like we saw in our case, you cannot rely on chemo to reverse that. Segmental resection is still the curative standard in that scenario.
Excellent. So let's finish with the 7 rules to take into clinic tomorrow.
Let's hear them.
Master the 2 doors of T4A. Remember, CT shows cortex, MRI shows marrow. Know the difference between marginal and segmental surgery. Treat the native stumps as the classic ORN risk. Make pre-RT dental extractions mandatory. Treat tumor-involved bone to fulgose. And always, always hit that 6-week PRT timing window.
And for everyone listening, a great practical step is to go review your own institution's guidelines on V60 and V65 constraints for ORN. That's where all this high-level evidence really meets your daily practice.
And you can complete your practice oral boards and access more resources at radontsmartlearn.com. Next time, we're going to transition from the oral cavity to the oropharynx and explore the massive clinical and staging shifts brought on by the HPV revolution.
A whole different world.
Thank you for joining us.